Live from the Washington, D.C. area, it's the Inside Scoop. All the news that our viewers want to know. Now, here's the host.
Good evening, and welcome to the Inside Scoop. I'm your host, Melissa Batchelor-Murphy, and we are continuing our healthcare series. And tonight we're going to be talking about state-of-the-art care for older adults. And one of the first programs that I wanted to highlight is a program that's called NICH, which stands for Nurses Improving Care for Healhsystems Elders. And they have found their niche within the hospital system and are working their way into nursing home care. So tonight I'm joined by Dr. Mattia Gilmartin, who's the Executive Director of NICH, and she's also a faculty member at the New York University Rory Myers College of Nursing. So thank you very much for traveling down from New York to be with us today.
Thank you so much, Melissa. I'm happy to be here.
So maybe you can tell us a little bit about what NICH is about, how it came to be, and the role that it plays in our health care system.
Sure. So NICH stands for Nurses Improving Care for Healthsystem Elders. We're a 25-year-old program based at the NYU Myers College of Nursing. So NICH started in the early 90s, I think really with a radical idea that was twofold. One was that older adults in hospitals were not really getting the quality of care that they needed, mostly because geriatrics was a relatively new field and there weren't many clinicians that had the expertise. And the second part of NICH was that nurses play a key leadership role in hospital settings to make change and to provide expert care. So the NICH journey began in the early 90s with funding from the John A. Hartford Foundation to test out this notion that nurses could be leaders and that if you put together models of care that are known to work and teach nurses skills to put them into practice, that change and improvement would happen. And so over our 25-year history, that's what we've been doing. The program's really gone through 4 distinct phases. So the early phase was really focusing on building the knowledge and the practices that work for making sure that when people go through a period of hospitalization, that they come out better than when they went in.
Right, which we're still even having trouble seeing that happen
today.
Yes.
Exactly. So first it was finding the evidence and then finding models from across the country that were being pioneered in schools of nursing and bringing them together in one place and then trying to transport them to frontline nurses in hospitals. So that's how the group spent most of the 90s and really the 90s through the 2000s. So finding the models, testing the models, showing that this idea could work. In 2010, I would say that was the third wave of NICH's development, where we received a large grant from the Atlantic Philanthropies to really scale and spread the NICH model. So in that period, all of our teaching materials and the materials that we have for frontline nurses, we went online and we were able to grow quite quickly from about 130 member hospitals to over 500 hospitals.
And what
by 2013.
Okay.
So in about a 5-year period, we added 400 member hospitals. Mm-hmm. Today we have about 751 hospital members, mostly in the continental United States, in 46 states. And we do have some international members, predominantly in Canada, Singapore, and 1 small hospital in Bermuda. And I've recently taken over as the executive director of the NICH program in September of 2016. So my goal is to spread the program to even more hospitals in the United States. So to see if we can move from our 12% of hospitals to 50% or more.
So that is great. And part of the reason we're doing this show is to help get the word out, that you started with just a few hospitals and over, 10, 15, 20, 25 years have been able to get to 12%. And this model of care, maybe you can tell us why this would be important if my mother's going to a hospital for me to know if they had a niche unit. Like, what would be different than a hospital that didn't have a niche unit?
Sure, okay. So the principles of the niche program, we try to influence four things in hospitals to promote quality of care for older adults. So first is that frontline nurses have the evidence that they need to deliver quality of care. Mm-hmm. So we know across healthcare that there is a problem that we have, that people like us in faculty roles, we create evidence and find things that work, but it takes more than 15 years for that to get into the hands of frontline nurses. So typically.
Yeah, and the other side with education is that most schools of nursing don't have even one faculty member with geriatric expertise. So
exactly.
As an academic nurse, we can hit new nurses coming in, but what you're doing with niche is kind of hitting that practicing nurse.
The practicing nurse, exactly. So to put the evidence in their hands in a way that they can use it in their daily practice. The second is our mission is to make sure that the environment of care is designed for the specific needs of older adults. So taking care of someone who's 80 is much different than taking care of someone who's 40. So mm-hmm. older adults have very complex needs, and of course there's very healthy 80-year-olds and there's very sick 80-year-olds. So it's understanding that the environment needs to be different, and by that I mean that you might need different flooring, or you have to communicate differently to someone who might have hearing or
visual
changes. The third part is to promote strong and autonomous nursing practice. So by that I mean that professional nursing has a specific role in identifying symptoms of illness and managing those symptoms, and teaching individuals and their family members to care for themselves most effectively, because ultimately nurses are trying to improve people's health.
True. Right, and we were voted the most trusted profession
yes.
for about 15 years, and so that's really good for us. And so I think what this model is showing is that nurses can take a leadership role and help influence a health system from that point of access when you try to come into your appointment, that you're greeted and the signage is large enough, and that then you have for your frontline nurses who can take care of you.
Right, exactly. So that's a key part of what we try to do. And so, we try to serve two groups. So first and foremost is the older adult that is coming into the formal care system. So historically in hospitals, and now we're moving into long-term care. And then second, we try to serve frontline staff nurses so that they can deliver high quality care, and that they know the right thing to do and are able to practice to their full scope of what the profession's vision of nursing.
Mm-hmm. And then I think the last part that we had talked about that was kind of the core value was around quality improvement.
Yes, so quality improvement. So we get to quality improvement through a few different ways. So one is that the niche program and the faculty, both at the College of Nursing at NYU and our colleagues in the broader network of geriatrics, have developed a series of protocols. So they've brought all the evidence into one place, again in service for frontline nurses. And we focus on common issues that older adults face, so both when they're ill or things that we know might affect their health outcomes when they're in the hospital. So for instance, that their skin is taken care of, that they're fed properly and have nutrition, that they are urged to get up out of bed and walk around so that their mobility is maintained at the end of their hospitalization that they come out able to walk like they did when they, arrived at the hospital.
Right, and I think part of what Niche is also doing is kind of combating ageism, because
Yes.
I tell my students, when you're sick and you're in the hospital, you can look like you're 10, 15 years older than you truly are. So
Yes.
kind of educating the frontline nurses that, what were they doing 2-3 days ago? If they were up playing golf, that's what we need to get them back to. And
Right.
that delirium doesn't necessarily equal dementia or Alzheimer's.
Right, exactly. So it really is trying to teach both frontline nurses and even more broadly the support staff in hospitals. So what are things associated with normal aging and healthy aging? And then what are common things for people that might have chronic diseases or are undergoing a period of acute illness?
Right, and kind of giving everybody a common language around these things that we call geriatric syndromes.
Yes.
So how many protocols do you have?
So right now there are 20.
Okay.
So there's the foundational piece of nursing care, so things like skin and not using restraints and nutrition and hydration. There's a set of protocols also on transitions, so how to design care as people move across levels of care, that's done effectively and in a coordinated way. We
Yes.
have new protocols on end-of-life care planning, so people who are, facing death in the end of their life, that they have a choice about what that looks like, and that their family has input, and that nurses play a role in designing that.
Yes, and helping families have those conversations.
Right, exactly.
So, and so now you're moving into niche, so maybe just very briefly kind of tell us why that was important and how long that's been undergoing.
Sure, so now we're moving into long-term care. So the whole idea behind niche is that nurses, wherever they practice, will encounter older adults, and they need to have the knowledge and skills to do that work well. And so we saw over time that many of our hospital members that also had long-term care services were using the materials designed for patients in the hospital and sort of moving it over to their long-term care facility. So again, with the support of the John A. Hartford Foundation, we have a new grant, and it's led by Eileen Sullivan-Marks.
Thank you very much.
Sure.
We will be back in just a few minutes to talk about 3 different organizations using niche.
Can we get strawberries? Okay.
Okay, so what would you bring to my company?
What do you need?
I need problem-solving skills.
I got through high school without a car, a phone, or a computer.
No college degree, though.
Not yet, but life's taught me a lot, and I'm ready for more.
Well, you're not the typical kind of candidate that I hire. But you are exactly what I'm looking for.
Your company could be missing out on the candidates it needs most. Learn how to find a great pool of untapped talent at gradsoflife.org.
They'll test you. Try to break your will. But however loud the loudness gets, however many cheese puffs may fly, you're the driver, the one in control. Stand firm. Just wait.
I'm like right up against this.
And move only when you hear the click that says they're buckled in for the drive. Never give up till they
Part of it
buckle
is
up.
because I'm like into this.
We're back to the Inside Scoop. Here again, your host.
Welcome back to the Inside Scoop. I'm your host, Melissa Batchelor-Murphy, and tonight we are talking about NICH, which stands for Nurses Improving Care for Healhsystems Elders. And Dr. Gilmartin just joined us and kind of gave an overview of NICH and why families of older adults should look for one in their area. And now we are joined by Dr. Maureen McCausland, who is the Chief Nursing Officer at MedStar Health. And she's going to tell us kind of describe the journey that you guys have been on related to NICH. So thank you very much for being here tonight.
Well, thank you for having me. Talking about NICH is actually one of my favorite things.
Great, mine too.
Yes. So at MedStar Health, we realized a number of years ago that it was going to be really important as part of delivering comprehensive care that we had the tools and the techniques and the evidence available to everybody who was taking care of elderly patients. So,
which is important considering 60% or more of people in your hospital units are probably over the age of 65.
Many units like that. And what began really as a nurse-initiated approach to the NICH program on one unit at MedStar Washington Hospital Center back around 2010, 2011 has really grown to today. We have all 10 of our hospitals recognized by the NICH program. And we have a large number of geriatric resource nurses. We have over 700. And it's truly an interdisciplinary and interprofessional approach to how we care for elders, with involvement with frontline staff, nursing assistants, our registered nurses, of course, who really drive the program, physician involvement, and a lot of support from our patient family advisory councils.
And so you had mentioned this geriatric resource nurse. So part of what NICH is like a philosophy of care, and then organizations can implement that in multiple ways, kind of based on those 4 cores that we talked about.
Yes.
So you mentioned, tell me what a geriatric resource nurse is. And
well, this is a nurse who has a commitment to the care of elders and who's very interested and passionate about learning more about how to care for elders. And then we are very fortunate to have the wonderful materials that come from the NICH program and our colleagues at NYU. So to be a nurse who's considered a geriatric resource nurse in our organization, they actually participate in the training that's available through the National NICH program. And they're unit-based. We have about 122 inpatient units across MedStar. Now, they do not all have elders on them.
Right.
But our
well,
goal...
they probably do in some capacity because grandparents come to visit.
That's true.
Pediatrics, and you know the grandmas are going to come to your labor and delivery floor.
They do. So these men and women have really volunteered and, you know, gone through a process with their manager and our leaders, have the education then via the NICH program. And then they are a resource to other nurses on the unit and other professionals with expertise and providing ways to coach and, as was mentioned earlier, you know, really look at the patient holistically. Understand where they came from before they joined us. I loved your example about being on the golf course.
Yes.
And we know that it's very challenging for patients to be admitted to the hospital.
It is challenging for their family members also.
Yes.
So your geriatric resource nurses do the online training offered by
They
NICH?
do.
And then do they do a project with that?
They will frequently do a project, and they're very committed to sharing those projects. They do posters. They educate other members of the team. And so we do a combination of online and face-to-face learning and development.
Okay. And you had mentioned creating posters and doing presentations. So we forgot to mention that the NICH annual conference starts this Wednesday.
Yes.
And you had mentioned that even your nurses are involved with that conference.
They are. It's actually one of the most meaningful conferences that MedStar nurses go to. This year we have 20 people going to the conference, and a number of them are presenting and sharing their work.
Right, so that's a great way to meet other nurses across the country and see what other health systems are doing.
Yes.
So what are some kind of the top projects that you think of that have really impacted the care that your nurses are able to deliver?
One that's underway right now, which is being led by our niche coordinator at the system level, is focused on improving pain management for elders. We have evidence-based guidelines, and those are shared widely, but we really thought that it made sense, and this actually was Karen Mack's idea, she's the coordinator, to take what was a broad goal for nursing across the system this year and say, what can niche and the nurses involved in that program bring to it? So that's, I think, a real-time example. A lot of work on fall prevention. And a lot of work underway at a couple of our hospitals, putting together materials for family members as well as the patient. And that's a place where our patient family advisory councils have been very engaged and involved in helping with that.
I think that making sure that your loved one's not in pain and that you have a nursing workforce that understands how, even if someone had a little bit of a cognitive impairment, how they might express pain differently.
Yes.
Would be a big thing for families.
Yes, and looking at how pain medications actually interact with the many other drugs that patients might be taking. I think is an important piece of that. And we're very interested in working with patients to understand how their drive for independence sometimes helps them make a decision to perhaps get out of bed when they're at risk for falling, without putting their call light on. And we have some ideas about a project related to that so that we can help meet patients' needs better.
Yes. Well, and I think that one of the great parts about niche is it sees older adults for the fact that just because you're 80, your personality and your drive for independence, if it's not stronger, it's at least equal to what it was.
Yes. And resilience is so important.
Yes, and then how do we as nurses support that resilience to help people get back home?
Yes.
So you have niche at some phase along kind of the continuum, so maybe you can talk about the history of niche within your organization?
Sure. So we began with that one unit at MedStar Washington Hospital Center, and today we have all 10 hospitals recognized. There's 4 levels of recognition that a hospital can achieve, and we're thrilled that we have 3 that are at the exemplar status. So what does that mean? I mean, they're recognized for doing an extraordinary job. And then the other 7 are senior friendly. So we've moved well beyond this being as important as it was in the early days, a nursing program, to really being an interdisciplinary program that our entire system recognizes. Karen, for example, did a education session for our board of directors about 2 years ago, and it was very well received.
So by age friendly and interdisciplinary, maybe you can say a little bit more about that?
Sure. I think it's a recognition that this is a program that is supported by our executive team, by our physician colleagues. It shows up as goals each year in our annual operating plans. It means we provide resources to support the program, and it's really embedded across those hospitals.
Yeah, so I think one of the important things to bring out is that in order for niche to be effective, that those barriers of resources, and dedicating resources needs to be something that hospitals acknowledge. So I do commend you guys for dedicating resources around the time that it's going to take for people to go through training, and then putting money into creating educational materials for families.
Yeah. We have we've had over 3,000 courses taken through the niche program online. Over the past 3 or 4 years, and people are able to do that, on their work time. We support that. If they want to do it in Other times, of course, we would, that's up to them, but there really is support for it. And there's really support as we look at our physical facilities and redo units or build new towers to make sure that we're building in appropriate flooring and contrast for people who may have some visual impairments so that they can walk more safely.
Yeah, I mean, just navigating a health system, if you're new to it, can be very daunting. So,
yes,
I think what the niche program does is help you really think through what's it like from the perspective of the patient once they arrive for care, and then how do we support them all the way through.
Yeah.
So you had mentioned your advisory board and how excited they were. So maybe you can tell us a little bit more about why this is exciting to them.
So we have at our system level a patient and family advisory council for quality and safety. And that particular council is made up from people around the United States who come and work with us at MedStar. And I think that the reason they are so supportive is, as we mentioned earlier, they know that we're addressing needs for a large patient population. We want that care to be safe. We want it to be high quality and using evidence that's available. So from their perspective, I think they look at a more global implementation, and they're really pleased that we're not just doing this in 1 or 2 hospitals, but we've said we do it across the system. Then each of the 10 hospitals has a patient family advisory council as well. And there you really can focus on the local community and specific patient populations. So for example, we have an acute rehabilitation hospital, and niche might look a little bit different there, than it does in a level 1 trauma center, which is right across the street.
Right, and I think that's one of the good things about niche is it gives each organization and each kind of area the flexibility to have people still delivering state-of-the-art geriatric care, just in the way that fits your community the best.
Yes, so what does that look like for acute rehabilitation patients? What does that look like, for example, for patients who might be cared for in our heart and vascular center?
And all with the mind of keeping people safe,
ultimate goal is safe.
And making sure that the care delivered is appropriate for that population.
And personalized, and that's part of the program as well.
Yes, making sure that personalized care is always a good thing. So, and you said you had about 1,500 PRNs?
No, 715.
715. Okay. Well, thank you very much for being with us tonight and sharing all the great work that MedStar is doing. When we come back, we will talk with Inova Fairfax and look at their exemplar model of care as well as Duke's niche program. And again, we'd like to thank everyone for being here to share their different experiences with niche.
You know what, guys? There's a lot of tree branches and dry brush over here. We should probably move the bonfire over there.
I'm guessing Smokey liked that idea.
Hey, Hard, what's this?
That's my resignation.
You're resigning?
Why? You've been putting me under a lot of pressure lately. That's why I'm ready to quit.
Oh, I forgot. I'll do better. Please don't quit on me.
Don't let your heart quit on you. Get your uncontrolled high blood pressure to a healthy range before it's too late.
So you can't save money? That's easy as pie. Brown bagging lunch instead of going out. $6 save times 5 days a week times 10 years is $21,000. That's a lot of lettuce. Small changes today, big bucks tomorrow. Feedthepig.org.
Did you know kids who play outdoors have healthier lungs?
Totally. I did. Did you know that boys that play with dolls make better husbands?
My son has lots of dolls. But did you know terry cloth diapers breathe better?
I did.
It's totally true.
Oh, yeah.
Did you know that strollers have the right of way on the sidewalk?
Yes.
Yep, I did. Did you guys
Did you know that kids who eat breakfast have higher GPAs?
Yeah, I know.
Yeah. That's actually what I was going to say.
Did you know babies should never touch silver? It's really bad for them.
I knew that.
Did you guys know that statistically friendly kids have more friends?
Mm-hmm. Yeah.
That's obvious.
Did you know most people think they're using the right car seat for their kid, but they're not?
Parents who really know it all know for sure that their child is in the right seat at the right age and size. Visit safercar.gov/the right seat to make sure your child is protected.
I'm putting that on my blog.
I just put it in mine.
We're back to the Inside Scoop. Here again, your host.
Welcome back to the Inside Scoop, and we're continuing our healthcare series talking about NICH, which is a program of Nurses Improving Care for Healhsystems elders. And it's basically delivering state-of-the-art geriatric care to older adults, because caring for older adults is different than caring for other populations. So I'm joined this evening by Dr. Deirdre Carolan, who is the director of the NICH program at Inova Fairfax Hospital, another exemplar of the NICH program. And they're in their 25th anniversary, but you guys have been there almost from the beginning. So
Since 2001.
Yeah, so maybe you can tell us a little bit about Inova Fairfax, their journey.
I'd love to tell you about it. Our journey really started in about 1998 or 99 when one of my colleagues, who was a ClinSpec in critical care, got her critical care bulletin, and there was a corner in it about a project that NICH had at that point called SNAP, and it was for specialty nursing organizations to get the nursing organizations to sponsor more geriatric care and increase their awareness of what was needed for the older adults. Out of that, I made a phone call and our NICH journey started. Number of things had to come first. We had to figure out how we were going to fund it, because there's money involved. And back in those days, in NICH, you went up to New York, to NYU, to attend a 3-day training session. Now it's all online. We also had to garner leadership support. We already had our geriatrician support. We actually had a geriatric consult service since 1985. And we recognized that there were gaps in the care we were giving our older adults. And this was a way to remedy some of them that was all nursing driven, which was wonderful.
And that's actually unique. I think that the NICH is really one of the most prominent models of care delivery that is driven by nurses. So you got your buy-in, you got your training.
We wrote a grant.
We
wrote a grant, and the annual gala was to benefit geriatric projects, and our proposal got approved and we were funded, and 13 of us went up to NYU to learn all about the models of care and about NICH.
Yeah, that's fantastic, and an amazing commitment on the part of the organization to do that.
It was a great commitment. I think we were the largest group up there, but we are in a somewhat transient area just because of the military and government employees, so we know people move through quickly, so we wanted to be sure we had a good cohort with us. We also brought a very multidisciplinary cohort. We had a nurse educator who was a champion for NICH. We brought our chief nurse with us. We brought a head nurse with us. There were 6 staff nurses from cardiac services, ranging from PCCU to CCU, an emergency department nurse, a medical nurse, surgical nurse, and we also had our social worker that was the champion for geriatrics as well. And all of us spent the weekend together, and we learned a lot, and everybody came back so enthusiastic. It was great, and it was wonderful to see, because sometimes you can feel like a voice crying in the wilderness a little bit.
True. So that's great. So even though it's a nurse-driven model, geriatrics has always been very inclusive, and we've always practiced kind of interdisciplinary type of practice. So that's great that you had that many people to go. And then one of the things that we have talked about is kind of modifying the environment. So I think before the show, we had talked about some of your early initiatives to make the environment more geriatric friendly.
When we came back, we were trying to troubleshoot everything we could think of, or brainstorm is a better word, and think of all the things we could put on our wish list. So we put on them that we'd like different TV programs, we'd like music programs, we'd like some activity carts, we'd like the ability to mobilize people, and we'd also like things to be more friendly so that the older adult could function better. And that was when we started going to all the environmental design, and any time there was construction or anything getting renovated, we'd show up at to represent the older adult and what was best for them.
Yeah. And that truly is pervasive. I mean, I moved here about a year and a half ago, and they're renovating the new Exxon building across the way, and I had a chance to talk to the architect and asked him, so what are you doing to make sure this is a geriatric-friendly environment? And he goes, don't worry, Deirdre's there. So that was even before we had met, so you have definitely made
I bet I know exactly who it is.
Yeah.
They actually finally put me on all the committees over there whenever they were doing construction.
Yeah. Which is great. I mean, you know, the thing with geriatrics is it's hard to have an advocate, and what this model does is it kind of helps nurses who can be in leadership roles to really help move organizations forward. And I know for Inova Fairfax, their community health needs assessment addressed that elder care is their #1 priority for the next 3 years. So that is fabulous.
Yes.
So after we have done the environmental stuff and you guys have been up there for training, one of the other things that niche does is it improves the quality of care for older adults. And when we say that, what does that really kind of mean? When we say quality of care, like what are some of the specific things that you guys have made a difference by using the niche program?
Well, there's a lot of specific initiatives. The overarching goal is that there is evidence-based research on what is best practice and best care for the older adult that is effective, it's cost-effective, and it also improves quality of life. Things that work in the older adult that may not work or are not the same as what would work in younger people. Mm-hmm. And as incorporating all of that into the various projects that we did. The things we focused on initially were everybody's looking at patient falls, and we focused on falls intensely. We also focused on delirium and the things we could do and put into place to improve the function of the older adults so that they wouldn't become delirious, and if they did become delirious, how could we remedy the situation appropriately and correctly?
And quickly.
And quickly, yes, shorten the duration of the delirious episode. But also that helped reduce falls, because if the patient is not confused and agitated, they're not going to be trying to get up out of bed, or they'll stay sitting in a chair. We want them out of bed, because that was another one of our first initiatives, was getting people up and mobilized.
Right.
Everybody thinks lots of times that it's safest to keep people in bed, that way they won't fall, not realizing that every day in bed increases their risk that they will fall, because as they weaken quickly in the older adult.
Yeah, I've told my students for every day that an older adult stays in bed, it takes them 3 weeks to get over that. So getting people up and moving, Tia in the beginning, Dr. Gilmartin mentioned, this radical idea that started 25 years ago. And, to me, it's like, it truly is a radical idea, but it's just hard for me to believe that it's taken us that long as a society to care about delivering quality care that's evidence-based for older adults. So
I think niche was successful because there were people that were interested. It's just nobody had a mechanism, and niche formalized that mechanism and gives you all the tools to work with. It gives you models of care that you can adapt. They're not prescriptive. You can individualize them to your particular facility or your environment, and even unit by unit as to what works best on your units.
Right, and that flexibility is what you truly need to have a movement like this kind of take hold. So you started in 2001, and now it's 2017. So what does niche look like for you guys today?
It's vibrant. It has now gone system-wide, first off. It's in all of our sister hospitals. We have 5 hospital system. When you go on the floors, you're going to see nurses that are talking to patients as adults, older adults, and even if they're confused talking to them. People don't walk by rooms where people are calling out. People are up, moving, walking around. You will actually see a discussion if a physician is proposing a medication that nurse knows is not recommended in the older adult, saying, that's really not the appropriate medication. Have you thought about using X, Y, or Z instead? Occasionally a physician wants to put a patient on bed rest. When we redid the standing orders, we took all the bed rest orders off. They have to be written in now. So that to emphasize the damage that bed rest can do to our older adult population.
True. And then the other initiative around quality improvement. So maybe you have a couple of exemplars of some of the geriatric resource nurses that have gone through the niche training. Like, what have they specifically done in units around Inova?
One of the MyStar units, which was actually our first niche unit, we went up unit by unit, is a medical unit. And they have continued to focus on the mobility issues. They have all their patients up 3 times a day now, at least, if they have any ability to get up. Patients are up for every meal.
Now that's music to my ears, since that's my research focus is improving nutrition. So that's a radical idea, but a good one.
They've had an influx of new staff. They were our delirium experts and would be called throughout the hospital to advise on patients who were confused and those who were demented as well, because both can coexist, as you know.
Right.
But sometimes the delirious patient, you don't know exactly what you're trying to get them back to at baseline if they already have some cognitive impairment. You will see that right now they're starting a new initiative to re-educate on the use of the confusion assessment method, which is incorporated now into our medical record on a daily assessment. We were noticing on the 8th floor that, they were 8th floor, they're 10 now, that it wasn't getting done quite as well and quite as consistently by some of the newer staff. So they're doing a new initiative now again to re-educate on it so that people will recognize when somebody's delirium, as well as then be able to take the appropriate actions and introducing them to the delirium order sets that are out there.
Yeah, I mean, I think you mentioned, with a transient organization like you guys have, that it is important to train new people and to continue to kind of keep that in place. And so one of the things we had talked about was, so what do you do for a new employee who's maybe never heard of niche? How do you kind of introduce the program to them?
On the programs that we're reinitiating the education, because this facility has made a commitment to 100% nursing education on the adult units. It's now being incorporated into orientation. The 20 hours for the RNs, 16 hours for the techs and aides, and then 5 hours for support service people such as the secretary, unit volunteers.
Right, because it's really, truly important for every person in the hospital to understand how caring for older adults should be different, even if it's helping them get from one part of the hospital to the next, to lower your voice, to speak slowly, kind of the basic communication skills that you have to have.
Absolutely, absolutely.
So what is your aspiration for Inova Fairfax in the next 5 to 10 years related to this program?
Well, we've been exemplar for 3 years. I'd like us to stay exemplar for forever. I'd like to see all of our construction continue to develop and be geriatric friendly for the older adult. And
that's from the first time when they hit your parking lot till
all the
they
way
get
out.
back in that
All the
car
way
to
out.
go home, hopefully not to a nursing home, but if they do that, even to have a smooth transition between the hospital and the nursing home.
And that we have continuity of care, that they see Inova as being a geriatric provider from start to finish.
Yes. And those are all great goals. So I'd like to thank Dr. Deirdre Carolan for joining us to talk about how Inova Fairfax has embraced the niche program. And when we return, we will talk about with a colleague of mine from Duke University's health system and their niche program.
One day these rats were playing in the woods. Wanted some matches and that's no good. Listen to smoke before you give it a try. Only you. Don't play with matches. Don't play with fire. Cause there's nothing very funny about rooftop life. Nothing very nice on a homeless mind. So if a gorgeous force is what you desire, don't play with matches. Don't play with fire. Yeah.
Only you can prevent wildfires.
Fire.
Why don't you just wash your car at home?
When I wash my car, everything runs down the street and down into the storm drains. With all the chemicals in the soaps and waxes, the last thing I want to do is poison my own drinking water. At least here, it's all contained and recycled on site. That's why I also take my car in for oil changes instead of doing it myself. I might take a chance on spilling stuff. You know what the best part is?
What?
More time to kick back and watch the game.
How far would you go to protect the planet?
I want you to build an ark.
Here we go. Okay, that's good. Oh, okay. Ow!
Maybe there's another way.
People, the flood is imminent!
Is it too much to ask for a little precipitation?
Go to fightglobalwarming.com to find out what you and your community can do to reduce global warming pollution.
Somewhere around the world, there are men and women of the armed forces risking their lives, helping rebuild communities after natural disasters, collecting toys for needy children, tutoring kids in school. These are your sons and daughters who work to keep us safe, secure, and free. Dedicated men and women who put their country first.
We're back to the Inside Scoop. Here again, your host.
Good evening and welcome back to the Inside Scoop, and we're continuing our healthcare series talking about NICH, which stands for Nurses Improving Care for Health Systems Elders. And we are joined now by Dr. Eleanor McConnell, who is an associate professor at Duke University School of Nursing and one of my favorite people. So thank you for driving up from North Carolina. I appreciate everyone for traveling to be here with us today. And you're also the director for our Center in Geriatric Nursing Education. So maybe you can tell us what Duke's path has been within the NICH program.
Sure, Melissa, it's great to be here. Duke's path to NICH, becoming a NICH organization, began about 10 years ago when Mattia, who was, I guess, the founding director of NICH, came to do a visiting professorship with us. And we decided that we had an opportunity to partner the School of Nursing with the health system to implement NICH. And 10 years later, each time things get better and better as we've moved from training one cohort of geriatric resource nurses at a time to seeing those nurses really make an impact in the same way that you've heard some of the other guests talk about making a difference at the point of care, helping older adults not succumb to some of the side effects of hospitalization, but instead gain the most from that hospitalization.
Right, so to go in sick and come out healthy instead of more frail than when you went in.
Precisely, precisely.
So in the beginning, maybe some of the exemplars of how you went about implementing the NICH model into, because we've heard about how different organizations kind of can tailor the NICH program.
Sure. So one of the key features of our implementation was the partnership between the school and the health system. And so we had faculty learning side by side with staff nurses and senior leaders within the nursing organization to attend the NICH conference that Deirdre talked about. We came back and decided to take ongoing training programs that the school had established for training pre-licensure geriatric nurses and join those with the knowledge that the bedside nurses had that wasn't quite up to snuff with respect to caring for older adults. They were great cardiology nurses or great oncology nurses, but they hadn't considered how it is that older adults might respond differently to their treatment. So over time, we developed a training program that included the expectation that the nurses would engage in a practice improvement project, and began initially with enhanced recognition of delirium or changes in mental status that often accompany acute illness, and have moved from there to development of more system-level delirium prevention programs that engage patients and families in doing the things that can help them maintain their cognitive status even if they are quite seriously ill. A couple of other examples of how it is that NICH has improved care in our system include some work that nurses on our acute bone marrow transplant unit have done to partner with clinical pharmacists to look at some of the protocols that are used to manage symptoms of people undergoing toxic chemotherapy. Many of the drugs that are used can be dose adjusted downward to decrease the likelihood that an older adult is going to experience adverse effects from some of those drugs to manage anxiety or nausea. And what will be reported later this week are some really impressive successes in reducing exposure to drugs such as benzodiazepines while people are undergoing cancer chemotherapy. So we couldn't be more delighted.
And so the NICH program, Duke's NICH will present that at the annual conference this week?
Correct.
Okay. And another So you've talked about delirium and the medication management. Tell me a little bit about the difficult conversations.
So last year, an opportunity opened up for the Hospice and Palliative Care Nurse Association to partner with Niche at the conference around geriatrics and palliative care coming together. And so our palliative care nurse practitioner, Jennifer Gentry, partnered with one of our School of Nursing faculty colleagues, Dr. Chip Bailey, and some of the geriatric resource nurses around, beginning to open up conversations around the end of life that for one reason or another, other clinicians weren't willing to open up. And so once again, they've partnered very successfully to help empower the nurses to recognize when a family or patient may want to have a conversation about how they spend their final days, and bring a team together to have that conversation in a systematic, patient-centered way.
So that is great. And then one of the, kind of the theme I hear you talking about is kind of how pervasive this, kind of the geriatric and state-of-the-art geriatric care is at Duke. And so one of your other roles is co-director of the Geriatric Workforce Enhancement Project. And in short terms, you call that a GWEP. We always have acronyms for everything, niche, GWEP.
And I'm told if you're in the West, you call it a GWEP.
Okay. Well, that's probably tomato.
There you go. But no, we're delighted to have had the opportunity to be awarded one of these geriatric workforce enhancement projects. They're a federally funded workforce development program that targets development of physicians who are in advanced fellowship training programs, nurse practitioners who are getting additional geriatrics expertise, and also provides education to pre-licensure students and also to older adults themselves and their family caregivers in the community. What we're probably most excited about is while Duke has a tradition of preparing specialists in geriatrics across the professions, this is the first time we've been challenged to really partner with physicians and other clinicians in primary care to try and raise the expertise of people caring for older adults in the community in geriatric specialty problem areas. So we've taken the geriatric resource nurse idea and tweaked it a bit to be more appropriate for use in primary care. We've established geriatric resource teams in half a dozen primary care practices in our community, and each of them, much like the niche nurses, have chosen an area of focus that is problematic for older adults to try and strengthen their practices in the clinics. So for example, detection or recognition of chronic cognitive impairment, Alzheimer's disease, related dementias, is a real problem in primary care, because if you don't recognize when someone has a dementing disorder, you don't necessarily make the adjustments that you need to in management of medications or providing other services. So we're working with one primary care practice to train the staff to recognize dementia when they see it. It may be due to it may present as medication noncompliance or other difficulties in managing chronic illnesses, and then do a diagnostic evaluation and wrap a package of services around that older adult and their family member.
Which is important. I mean, primary care providers probably have the most touch points with patients and their families. And if you only have 10 to 15 minutes, most people in the early stages can hold it together long enough to get through that particular interaction with a care provider. So it's important for primary care providers to be asking those questions.
And it's also important for their teams to understand what the issues are. So as you say, an older adult with chronic cognitive issues may be able to hold it together for a brief encounter, but it's hard to hold it together across multiple encounters in that same clinic visit. So we're encouraging training for the medical assistants in the clinic, as well as the RN care managers, the PharmDs, and the social workers, as well as the primary care providers.
So it sounds like you've taken a lot of the niche kind of core philosophies and integrated them a little bit into the GWEP and kind of definitely broadened to other disciplines beyond nursing.
Absolutely. We also are addressing senior communities in our region to try and help them be more proactive in asking their primary care providers or others to not chalk things up just to old age, but more to really investigate causes of weakness or difficulties in thinking rather than assuming that it's old age.
Right, and I think that's probably the biggest challenge we have in geriatrics is that people don't really understand what's normal aging. We have all of these myths around, well, it's normal for my memory to be slipping, or it's normal for me to be having incontinence, and those actually aren't normal parts of aging, and that they do need to be addressed. So you're addressing ageism as well as giving kind of the boots on the ground clinical skills that our broader workforce is going to need. Are you staying just within healthcare systems, or are you working with other types of people in the community?
We're working with pretty much anyone who will agree to partner with us. And so one set of partners that we've reached out to are people who are working in the home care environment. We've sponsored something called the Dementia Roundtable, where we've tried to provide a very engaging, continuing education approach to people who are providing personal assistance to older adults in their homes, as well as for people who may be working in nursing homes, assisted living, or even in PACE programs, Program on All-Inclusive Care for the Elderly.
Yes.
And by bringing those diverse people together and having them listen to the concerns that they each have, we see a real opportunity to raise the collective knowledge of how it is to care effectively for people with dementia in the community. And that's been an important part of the GWEP or GWEP focus, to strengthen community capacity to care for people with dementia.
Yeah, because obviously the demographic shift of the numbers of older adults that we'll have, is definitely on the rise. And so the more people we can kind of get into thinking about geriatrics, because I hear things all the time and I'm like, oh, that's not quite, how I would have interpreted that, or, so this is great stuff.
Well, the other thing that we're very excited about is the prospect of collaborating with some of the other GWEPs or GWEPs across the country. There are about 50 of them, to try and take a more intentional approach about preparing the next generation of caregivers for older adults. So we have a colleague who works in an adult day program in the Chapel Hill area who is spearheading a North Carolina-based elder care workforce coalition. Mm-hmm. And we're hoping to figure out ways to draw younger people into care for older adults. And we think that's going to be an important step to make sure there are caregivers for you and me.
That's true. So building the geriatric workforce is always a hot topic for me, and thank you very much for being here and sharing all of the great things going on at Duke. And we'd like to thank all of my guests for sharing their experiences with the Niche program, and we wish everyone at the Niche conference a great time next week.